Hi everyone, Spouse Angle host Natalie Gross here. This episode is about upcoming changes to military healthcare, and since my interview with today's guest, the military has come out with a big update. They are going to hold off on implementing some of the changes you'll hear us talk about today because of the coronavirus pandemic, and they will do some reevaluating before moving forward toward the end of the year. I will add a link to more information on this update in the show notes, and you can also find more information at thespouseangle.com. Now, on to today's episode.
I think the main takeaway for military families is that you have two major initiatives underway that could result in military families and retirees being moved out of their military treatment facilities and into civilian care.
You're listening to The Spouse Angle, a podcast breaking down the news for military spouses and their families. I'm your host, Natalie Gross, and this is episode 33. Hi, everyone. Thanks for tuning in to another episode of The Spouse Angle. The military has released a plan to downsize or close a number of military treatment facilities, which could have major implications for families seeking medical treatment on base. The military health system has said that these changes reflect the department's underlying principle to improve force readiness. Basically, a review of more than 300 of these facilities showed that military providers weren't seeing the type of cases or necessarily the volume to maintain proficiency in the type of medical care that they would be expected to provide downrange. That's according to an article by Federal News Network. But the plan is controversial, especially in the wake of the coronavirus and the impact that it's had on the military and civilian healthcare systems alike. So, here to break it all down for us is Karen Rudicelli. Karen was an Army spouse for many years before her husband retired and is now the Director of Government Relations for Health Affairs at MOA, the Military Officers Association of America. During the month of May, the organization led a charge for military family members and advocates to contact their representatives in Congress, asking them to reconsider these pending changes. So, Karen is on with me today to explain the pushback, especially, like I said, in a global pandemic. Karen, thanks so much for coming on the podcast today.
Thanks for having me, Natalie. I appreciate it.
So, I want to start by asking you to give us really a lay of the land. What changes and cuts are coming to military treatment facilities, these military hospitals, and military healthcare? And I'll go ahead and throw the questions when and why at you, too.
Sure. Yeah. And you know what? There is so much happening right now. I'm going to try to keep this succinct. But there's really two main things I think your listeners would be interested in. Things that may result in military families being moved out of their military treatment facilities and into the TRICARE civilian networks for their health care. So, the first thing is legislation that was passed by Congress with the fiscal year 17 National Defense Authorization Act. In that legislation, Congress passed many provisions to reform the military health system. These reforms are touching pretty much every aspect of military health care, and some of them have already gone into effect. Some military families probably have realized that they're paying higher copays when they go to provider visits, particularly if they're using TRICARE Select or if they are retired families. Another thing that military families may have noticed is that TRICARE now requires an annual enrollment, and that was not the case until January of 2018, and that was part of military health system reform. The latest development and the thing that's moving from kind of the 2 to 3 year planning stage that it's been in to now the implementation phase is this whole idea of restructuring military treatment facilities. So, the Defense Health Agency is looking at downsizing some of the smaller MTFs and even closing some in order to consolidate a lot of the uniformed medical personnel in more of the major military medical centers. And that has the potential to impact families because the families who receive care from those providers who will be moved out of the smaller MTFs and into the more major medical facilities, those families will likely be moved out into the TRICARE network for their care. There was a report that was released in February that detailed 48 MTFs that are being proposed for downsizing or closure. And that is kind of one of two main initiatives that are happening that could impact where families get their care. The other major thing that's happening, and this is a completely separate line of effort, although it sounds very related, is that the Department of Defense announced plans to cut approximately 18,000 medical billets or uniformed medical positions as part of the fiscal year 20 uh, administration budget request. And that plan was reiterated in the fiscal year 21 budget request that was released earlier this year. So that would mean about 20% of the uniformed medical force would be cut. Now, those aren't all providers. They're not all doctors and nurses and physician's assistants. Some of those roles might be administrative or other roles that aren't patient facing, but certainly a cut of that magnitude has the potential to impact military families. We have had less visibility on these billet cuts relative to the MTF restructuring, but it is our understanding that these billet cuts are being driven by the 2018 National Defense Strategy, which has really placed an emphasis on increasing lethality within the services. But I think the main takeaway for military families is that you have two major initiatives underway that could result in military families and retirees being moved out of their military treatment facilities and into civilian care.
And it hit home for me because I was looking at that list of 48 hospitals that can downsize or be cut. And the hospital I grew up going to and that my parents still go to is on that list. And that's the one at, I guess it's now Joint Base Langley Eustis. They each have a military treatment facility there. So,
Right. That is probably that's the biggest cut in terms of the MTF downsizing that's proposed. That's the biggest change would be at Joint Base Langley Eustis.
and our listeners, just so you know, you can find that list on MOA's website, and I will include the link to that in the show notes so you can find out if you're going to be impacted that way. Karen, what segment of the military population would be most affected by these changes? I mean, it really affects everybody, right? From active duty to retiree.
You're absolutely right. Everybody has the potential to be impacted by this. We've gotten a little bit of visibility, as you mentioned, in that February report that lists the 48 MTFs that have been proposed for restructuring. But that really, those are the changes that involve infrastructure. The billet cuts, we have no idea where those are coming from, and those could impact anybody, any military family member or retiree who currently get their care at the MTF. Um, One thing we do know from the February report is that if all of those 48 MTFs were downsized or closed, according to the plans that are outlined, that would impact about 200,000 beneficiaries. And I think it's helpful to understand the magnitude of that. By our calculations, that's about 10% of prime enrollees who are enrolled at MTFs. And it's close to an even split in terms of active duty family members and retirees that will be impacted. So of those 200,000 beneficiaries who will be impacted, 40% of those will be active duty family members and about 60% will be retirees. Um, I would want to point out, though, from a cost standpoint, an out of pocket cost standpoint, the impact will definitely be more significant on retirees. Active duty family members face no out of pocket costs for their care if they are enrolled in Prime and they follow TRICARE's referral authorization rules. However, retirees only have no out of pocket cost care if they get their care at MTFs. When they are transitioned out into the civilian network, they will face copays when they have provider visits.
If these proposed changes go through, how quickly is this set to take place? Will it be many years that people will transition out into the civilian sector, or will it be relatively quick that people will have to go find new doctors?
Well, this is a bit of a tricky question and answer. The The plan is that this will roll out slowly over the course of several years. So part of the answer is that the plans that have been discussed, the billet cuts and the restructuring of the 48 MTFs, that those should not affect people for at least a few years. It's important, though, for families who use MTFs to understand that there are a lot of different things that could transition their care into the civilian market that are kind of unrelated to these initiatives. So, if you're at an installation that has a major deployment happen and a lot of your uniformed medical providers end up deploying, well, your care might transition out to TRICARE providers temporarily. That would not necessarily be part of these initiatives. So it does become confusing for people because we say, oh, this is something that's going to roll out slowly. There won't be any sudden changes. But the nature of the direct care system is that people move in and out of it relatively regularly for a variety of reasons that aren't necessarily related to billet cuts or restructuring efforts.
That's already taking place, you're saying?
That's already taking place, and it has taken place, probably for as long as TRICARE has existed to as a relief valve for the direct care system.
Gotcha. Well, I think it's fair to say that MOA was against these cuts pre-COVID, and now it would seem even more so in light of the coronavirus, right? Can you explain how the pandemic has raised the importance of this issue in your eyes?
Sure. And, just to clarify, in terms of the military health system reform and the restructuring of MTFs, MOA was not necessarily opposed to that. We understand that the direct care system, the military hospitals and clinics, they exist to train uniformed providers so that we have providers that can be deployed to support our service members in operational environments. And if there's a better way to do that, that requires 10% of beneficiaries to be moved out into the TRICARE network so that we can take those uniform providers and move them to major military medical centers where they can get a more robust caseload or a better mix of cases to prepare them for what they might see in a deployed environment. MOA is not opposed to that as long as beneficiaries who are affected maintain access to high quality care. So just to clarify that point,
Sure.
delivering beneficiary care is kind of a it's an out it's kind of a result or a consequence of having that system. It's not the reason the system exists. And so it's very hard to argue that, military families must be seen in military hospitals and clinics if there's adequate care in the community that could provide high quality medical care for them. And that's, it's a struggle to kind of balance because there are impacts. I mean, it may be less convenient for a military family to go outside the gate for their care. For a retiree, it certainly is going to cost them more. But at the end of the day, it's important as advocacy organizations to kind of acknowledge that these military hospitals and clinics really exist as training and readiness platforms.
Yeah. The question is now, will the civilian community be able to handle this influx of military patients or potential
That
influx?
that is the key question is can these civilian communities handle the influx of patients? And to the Defense Health Agency's credit, there are certain installations that they never even considered for restructuring. So places like Fort Polk, Louisiana, or Fort Irwin, California, in the middle of the desert, it was understood up front that these surrounding communities would not be able to absorb the influx of patients. I think where there's gray area in a lot of other communities, and the fear is always that despite everyone's best intentions, mistakes will be made, and DHA will get it wrong in some communities, and some Families may be left struggling to access care despite everyone's best intentions. And that's really why we are pushing so hard for rigorous analysis and reporting and making sure that there are mitigation plans in place if people do encounter problems with accessing care. We have been more concerned about the billet cuts just because it has been very unclear as to what is driving those. They seem to be much more significant in terms of the number of uniformed providers that might be affected. There's just been less visibility on that. So I would say MOA has been much more concerned about the billet cuts. But to your question, what does coronavirus have to do with all this? There are kind of two sides to that answer. The first is that, in March, when we initially raised this issue, we had active duty medical providers who were gearing up to man field hospitals in cities across the nation. We had the Navy hospital ships, the Comfort and the Mercy, that were preparing to deploy. Governors across the country who were becoming concerned about whether or not their states' civilian medical systems could handle an influx of COVID-19 patients were turning to DoD and were saying, what can you do to help us if we need help? And that real life response to a national pandemic, we felt, should really inform um, the military medical readiness requirements. And what do I mean by that? Um, how many uniformed medical providers do you need? What types of uniformed medical providers do you need for the missions that the services and DoD are going to undertake? The medical readiness requirements that have been driving the military health system reform effort, were analyzed, many years back before COVID-19 was even a thought on the radar. And now that we've had the benefit of a whole of nation interagency response to a national pandemic, we believe it would be worthwhile to go back and revisit those military medical readiness requirements and ask, what sort of surge capacity does DoD Medical have to have in order to be able to respond in a national medical emergency? What role does military medical R&D play, in this instance, in the development of testing and vaccines? Um, how will DoD be involved in a future pandemic prevention efforts? These are all questions that we believe really need to be addressed before you start making cuts to military medical billets and military medical infrastructure. And then the other side of that is the current condition of the civilian healthcare system. So, part of the plan with reducing the capacity of military medical is that we will move military patients out into the civilian network for care. And the Defense Health Agency has been conducting research and analysis and due diligence to make sure that the care is out there if they move patients into the civilian network. Well, right now, that civilian network of care is in total flux. Segments of the healthcare system are at capacity or at close to capacity, emergency rooms, intensive care units, respiratory therapists, but a lot of other care has really just ground to a halt. People don't want to expose themselves. They're practicing social distancing. They aren't seeking out preventive care and other non urgent care the way they would be otherwise. And it's creating a lot of financial strain within the healthcare system. So we have major civilian hospital systems that are doing layoffs. Small provider practices or independent practices are facing financial strain, and it's unclear as to how many of them will survive this. So it really, at the other side of this equation is, at this point in time, we don't think DHA could really accurately assess the availability of civilian care for our military folks who would be transferred out of MTFs. And it's really unclear at this point as to when things will normalize, and an analysis like that could really be conducted effectively.
You spent the last few weeks sort of leading this charge for your members and military families to do what you call storm the hill, asking
Mhm.
people to contact their lawmakers. And this was all done virtually this year. So I want to learn more about that and what kind of response you got, both from the military community as far as participation goes, but also from lawmakers and even DOD.
Right. Yeah. It's actually been very successful. I mean, converting an in person event where MOA members from around the country visit our offices and we spend a day on Capitol Hill visiting every lawmaker, converting that into a virtual format on the dime really was a challenge, but our members have responded. We've had thousands of calls and letters to member offices. We've had hundreds of visits with members of Congress and their staff, by MOA members, by all measures in terms of executing it. It has been very successful.
What kind of responses were you getting?
Two offices, Representatives Posey and Castor from Florida, have initiated a Dear Colleague letter that they circulated, expressing their concerns about these potential cuts and how it could impact access to care for military families. And that letter went to HASC leadership. I think it's done a great job of raising awareness on a very complicated issue, and has allowed us to have a huge number of conversations on the topic in a very short period of time.
When do you think we'll know more and if your efforts paid off?
Well, from my perspective, I think the efforts have already paid off. We've had concerted outreach. Like I said, we've managed to raise awareness on this issue very quickly. We've got offices that are taking action in terms of circulating and signing on to this Dear Colleague letter. Of course, our ultimate goal is to get a provision in the NDAA that would officially put a halt to these efforts until we could re examine them. I think we've really already achieved some additional congressional oversight on these critical changes.
And for those who don't know, NDAA stands for National Defense Authorization Act.
Yeah.
Karen, is there anything else that you wanted to add on this issue?
You know, there are some legitimate goals and objectives that Congress has for MHS reform. And I would urge military families, retirees, and other beneficiaries to really try to keep a bit of an open mind as they hear about some of these reform efforts. Um, as Congress pursued the reform legislation, the year and a half before they introduced the legislation, they had a series of hearings and listening sessions and panels, and they talked to beneficiary organizations like MOA, and like they spoke with providers within the military health system. They did a lot of research to try to figure out where were the areas for improvement and how should we structure things moving forward. And you know while organizations like MOA and others have definitely spoken up where we've seen things that maybe aren't going in the direction that would be best for beneficiaries, I do think there was some good intent there. And I think that some of these moves have the potential to address concerns that people have raised over the years, such as lack of continuity with providers. So, one of the things we hear from military families all the time is that I never see my PCM. Every time I go in, I see a different doctor. And that can be a real issue, especially if you've got a chronic condition. Um, some of these changes have the potential to improve that. And we're behind efforts that will improve access to care. And continuity of care and the patient experience. I would, we're on the lookout for things that will not help and might in fact hurt those things. So you can be assured there are organizations like MOA out there that are playing the watchdog role in that respect. But I would ask people to not automatically jump to the conclusion that every change they see is for the worse.
Is Congress driving these changes or is DoD?
Well, it's a combination, really. I mean, Congress was behind the military health system reform legislation that passed with the fiscal year 17 NDAA. It's possible that DoD influenced that to a certain extent behind the scenes, but out front, it was Congress that was leading the charge on that. But that's where it becomes confusing with the billet reductions because I don't believe those were congressionally mandated. That looks to me like it came out of the Office of the Secretary of Defense. And, the stated explanation was that we want to convert more assets to lethality roles. And this is one of the ways that we're going to do it. So it is a combination. I would say for military families, it's important to keep in mind it's not the folks at TRICARE who are driving this. It's not your contractors. When you call Humana and HealthNet, they're really just implementing what they're being told to implement. So if you are frustrated, please contact your member of Congress and let them know that you're unhappy with some of these changes. I know it's tempting to unleash the fury on the contractor that you call for TRICARE questions, but really they are just implementing these changes.
Well, Karen, this has been so helpful to have an overview of what is to come. Thank you so much for coming on the spouse angle and breaking it down for us today.
Oh, no problem. My pleasure. Thanks for having me.
Thanks for listening to this episode of The Spouse Angle. Another update since my interview with Karen is that an early version of the National Defense Authorization Act that you heard her talk about does include two provisions addressing MOAD's concerns. The NDAA is still a long way from becoming law, but I wanted to include that update for you as well. You can find all previous episodes of The Spouse Angle at thespouseangle.com and your favorite podcast app. That's it from me, everyone. Talk to you next week.